Hello, and welcome to the Duke Endocrinology Conference. I'm Diana McNeill, Professor of Medicine at Duke University Medical Center. Today's program is titled Polycystic Ovarian Syndrome, Recognition and Management, and our distinguished guest is Anne Brown, Associate Professor of Medicine at the Duke University School of Medicine in Durham, North Carolina. Anne, thanks for joining us.
I'm glad to be here.
So, Anne, what can you tell us about polycystic ovarian syndrome?
Anything you want to know.
I'm excited.
Now, I love taking care of women with polycystic ovary syndrome because it really brings together the metabolic, reproductive, and psychological aspects of healthcare for women, which I really enjoy. So I'm going to talk about a case and talk about how you might approach general management.
Okay.
Sound good?
That sounds excellent.
All right. Well, we'll get started. So for CME purposes, I just wanted to say at the end of this program, you ought to be able to recognize women who have polycystic ovary syndrome based on their medical history and their exam. So without necessarily even ordering labs, you should have a sense of who might have PCO, order appropriate initial labs, and then counsel them on reproductive and metabolic consequences associated with polycystic ovary syndrome.
And Anne, would you agree that this is an increasingly recognized condition among women? I think in older days we probably weren't aware of it.
Yeah, it's a real interesting history where it was discovered or described in the in the 20s, but then in the late 80s, a woman named Andrea Dunafe at Northwestern started doing research on it and sort of revitalized some of the work on it and showed that these women have serious metabolic problems that need to be attended to. And so really it's been since maybe about 1990 that awareness has increased. And now we're at the point where I think people are pretty aware of it, but now they're just aware enough to be confused about what to do.
Okay.
So that's what I'm hoping to, I hope to answer some of those or address some of those areas that are confusing.
Okay. So tell us about the case.
Okay, so this is a patient that I saw in 2001. And she was 36 at the time, and she had a typical PCO pattern with menses about 2 to 4 times a year. She had hirsutism and alopecia, and she reported that she plucked and shaved her beard area and that she had some scalp hair loss in a male pattern. And she also complained of a dirty neck that she couldn't get clean, and she was overweight and had difficulty losing weight.
So, Anne, some of the terminology can be sometimes confusing when we're looking at patients like this. So women will sometimes come in and say, my hair is thinning, I'm losing a lot of hair. Is that what you mean by alopecia, or is that something different? Alopecia,
by that I mean generally hair loss, and hair loss in a particular pattern. So there's sort of a female pattern, a male pattern, and generalized diffuse. This is particularly a male pattern hair loss. Let me show you. Actually, I have a few more slides before we get to the pictures where I'll show you this. But she had so important medical history, no exogenous androgen exposure. I have seen patients who come in with similar. I had one patient, similar complaint, but she was taking an extract that had testosterone in it.
And weren't some of our colleagues perhaps thinking about using testosterone for libido issues? And so sometimes women might be using that and be...
Well, I hope not, but yes, you do want to screen. When you see somebody who has hirsutism, of course you want to screen for whether they're getting it externally. She did have a family history of type 2 diabetes, which is important because that raises her sort of her genetic risk for diabetes, and she was not currently interested in fertility. Her blood pressure was 132/80, which is pretty, it's a little high for someone who's 36. She was 195 pounds and 62 inches, so her waist circumference was large at 42.
And why did you mention the waist circumference as opposed to BMI or anything else?
Yeah, the waist circumference is important in predicting metabolic disease, and so it's... we try to remember to do it. BMI is another one that we can use. Waist circumference is good to do, but it's kind of complicated it's not always apparent where you do the measurement, where in the waist you do it, and what the right measurement is. So it's a little bit...
Yeah. I've been telling patients now that a tape measure is cheaper than a scale, and so if you really want to keep an eye on your weight loss, you might just measure the waist circumference because there seems to be more data associated.
Yeah, and if you suck in, it gets smaller.
That's right.
So anyway, she had hirsutism with a Ferriman-Gallwey score of 12, and the Ferriman-Gallwey score is a scale, which I'll show you in a second. And widened part width over the vertex of her scalp. She had acanthosis nigricans and pale striae.
Widened part width.
Yeah.
You're talking about the hair part?
Yeah.
Okay.
I'm going to show you that to you.
Okay.
So here's a picture of a patient of mine. And what is that called? That is the dirty neck.
Okay.
And she couldn't get it clean.
All
and
right.
Why not? Because it's acanthosis nigricans,
All
which
right.
is a sign of insulin resistance.
So that means that just because you have acanthosis nigricans and you're a woman doesn't mean you have polycystic ovarian syndrome. You get those other things can cause it, right?
That's right. It's not a sign of PCO. That's a really good point. It's a sign of insulin resistance.
So I also have seen a patient who was on niacin who got acanthosis nigricans. So some of the medications perhaps that can cause insulin resistance could also do it maybe.
Yes, absolutely. Okay. But it is something that I look for in women with PCO because I know that they're more predisposed to have insulin resistance. And so if I see it, then I'm concerned about their diabetes risk.
All right.
I always look under the chin because that's an area that doesn't get as much cosmetic attention, and I can see the hirsutism a little better there.
Okay.
And you can see that she's got thick hair follicles where she's shaved. Here's what I mean by the part width. So this is a good way if somebody's talking about having hair loss over their scalp and you're wondering if it's androgen related. One thing you can do is compare the width of the part in an androgen-sensitive area, like the frontal area or the vertex area.
Okay.
Compare that part with the width on the side.
With the width on the side. Okay.
Right. Say that 5 times. But it's because this is not an androgen-sensitive area over here. So that is a useful place.
I had not ever thought of using that as a physical exam finding for hyperandrogenism. It's a unique pearl.
I learned it from my dermatology friends.
Very good. Good.
Yeah, I didn't make it up. I promise. And this is acanthosis nigricans in a black woman.
So the question patients ask, and we may be a little bit jumping ahead of the final answers to the management of PCOS, does this go away? If you treat PCOS or manage the metabolic syndrome, does acanthosis nigricans go away?
Well, what I'd say is that in some of my patients it has.
Okay.
And, well, it's difficult for a lot of people to, we don't have a large number of people who lose a lot of weight.
Right. Good
and
point.
thus give us the chance to see whether the acanthosis goes away. But I have definitely heard it from more than one patient that it gets a lot better with weight loss or with insulin sensitivity, insulin sensitizing drugs.
Okay. Very good.
So it's a possibility. Certainly scrubbing it is not going to help.
Right. Patients are reassured when you give them an explanation for it because they thought something else was going on.
That's right. And I actually heard a talk, a call-in radio show where a mom was calling about her kid who had this dark, dirty neck that she couldn't get clean, and the pediatrician didn't pick up on, who was on the radio show, didn't pick up on the fact that it sounded like acanthosis nigricans. And of course, kids can get this. Kids can get type 2 diabetes, and so, one of my hobbies is standing in the grocery store line and looking at the necks of people in front of me, and it's very common.
Yeah. So you look at necks, and I look at thyroids. We're probably a bad couple.
So the front and the back. So in this patient, I did my metabolic workup, which includes a thyroid profile and a prolactin, because those are things that can cause irregular periods.
Okay.
And then I do an oral glucose tolerance test, and her glucose fasting was 90, and it went up to 130 at 2 hours.
Can you explain a little bit about the details on the oral glucose tolerance test? Because I would suspect a lot of our listeners have been told, with all the new guidelines for diagnosing diabetes, that we don't need to do oral glucose tolerance tests anymore unless you're pregnant. So which dose are we
I do them with PCO, and I would suggest doing them with anybody who's high risk because, as you know, the first thing to go bad in diabetes is the postprandial blood sugar.
That's right.
So well before the fasting goes up, well before the hemoglobin A1C goes up, the 2-hour glucose will be elevated. And so what I'm trying to do is detect it super early so that these young women who are in their 30s and 40s and 20s even can work on preventive measures while they're still very young, because they are high risk for going on. If they have a 2-hour glucose over 140, which is the cutoff, they're very have a long life ahead of them where they're at risk for diabetes. And so
now on this slide, Ann, you also have underneath the glucose levels insulin. Yeah. So why are you doing the insulin levels?
Okay. Well, first of all, I'll say that not everybody does them.
Okay.
But I like to do them because they're a marker. They're a way for me to see if someone has insulin resistance. So in this case, this woman has a fasting glucose of 90, which looks kind of normal.
Right.
But what I can tell by that insulin of 21, which is above the cutoff of 10, is that it's taking her a lot more insulin to keep her blood sugar normal. And that's sort of the definition of insulin resistance. So she's requiring a lot more pancreatic beta cell activity to keep her blood sugars normal. And you can just imagine this pancreas churning out insulin in order to keep the blood sugars normal. And so the reason I check insulin levels is to be able to give the feedback to the patient about whether they have insulin resistance.
Okay. Now there's another lab that some of our listeners might occasionally order called a C-peptide, you know, which measures your own insulin production. Do you check that in patients with PCOS, or is that not as useful?
I don't usually check it. Where it's useful is in when we're trying to distinguish between someone's native insulin production and and the exogenous or injected insulin that they're taking. And these women are generally not diabetic, and so they're not on insulin.
So we wouldn't do a C-peptide.
But you could do a C-peptide, and I would expect that it would be high. These normal values come from Andrea Dunaf's work, less than 10 fasting, 2-hour value less than 40 being normal. They come from her research, from her, the graphs on her papers, and so I have those data. I don't know offhand what a normal, what a C-peptide that would show insulin resistance would be.
Now, I'm also impressed in your patient that if I was looking at her lipids, she's got a lot of good cholesterol.
Yes, she does.
Is that unusual for a patient with PCOS?
It is. This particular person
lucky
had a very nice HDL cholesterol and LDL cholesterol that was nice and low, and often women who have sort of this metabolic picture actually have a lipid profile that looks more like metabolic syndrome profile, which would be a low HDL and a highish triglyceride. So her triglyceride is a teeny bit high, but she might not be fasting at the time that was done. I'm not sure.
What number are you trying to keep your triglycerides under right now?
Well, I think that normal's up to 150, and so above that I start to worry. So, and then her liver tests were normal. So that is her, and so this is how I think about and remember at any particular clinic visit to cover all of the territory, and also how I teach residents to try to keep track of all the things they need to think about with PCO. So it's a mnemonic that Tracy Secchi, a fellow, and I came up with and actually published a while back called My PCOS. It was My PCO until some data came available on sleep apnea being more common in PCO, and so we added the S, and it was good that it was sleep and started with an S.
The only one I won't remember is cycle because of the Y.
Because of the Y. I know. Well,
we'll get it. I'll practice.
But, the DCRI is famous for making up names like this and taking liberties, and so I figured I could too. Okay, so, so one of the things I want people to understand is how to make the diagnosis. And essentially anyone with irregular cycles, chronically irregular cycles, and evidence of hyperandrogenism probably has PCO once you rule out a few other causes. And that is essentially how most people were making the diagnosis based on an NIH conference in 1990. And this was important for being able to do research and having a kind of cohesive group of people in your study. As you can see, there's polycystic ovaries are not on that list at all, and that was because a lot of women who have the syndrome have normal-looking ovaries on ultrasound, and so ultrasound didn't seem to be a reliable way to rule in or rule out PCOS. And so in the more recently, the Europeans sort of argued for adding polycystic appearing ovaries by ultrasound as one of the diagnostic criteria.
So, Anne, let me ask a clinical question based on a case. So I've had a patient come to me more than once whose chief complaint is hirsutism. And if you define it by exam, it's essentially, the excessive hair on the arms, perhaps a little bit on the chest. They don't always have the criteria to be high scoring on the hirsutism scoring. I get a testosterone, and it's normal. Do you have to have an abnormal testosterone to confirm the diagnosis of polycystic ovarian syndrome? Because you have the word "or" on your slide.
Yeah.
And that's where I think some of us get confused because, if you are looking for hyperandrogenism, do you always have to have a high testosterone?
No. And there's a couple of reasons for that, and it's a really good question. So first of all, I want to make a comment that if a woman is concerned about her hirsutism, that's enough for me to call it hirsutism.
Okay.
So even though I use the Fairman-Gallwey score, which I'm going to show in a little bit, to quantify it, that's just so I can standardize it in my own clinic.
Okay.
It's not like you have to get above a certain amount in order to be considered hirsute, though according to the people who developed the scale, a score of 8 or greater is abnormal. So up to 8 could be normal. But if a woman comes and she's concerned about the hair growth, I think it's important for you to not argue with her about whether she has hirsutism or not.
I agree.
The other question about the testosterone value, a lot of women will have normal testosterone values, and really the major reason to check, I don't actually check it on everybody. If they have hair growth, and it's been slowly progressive, then I say, you know, that's hyperandrogenism. Now, there are a couple, so where do I start? One problem is that testosterone assays are terrible.
That's exactly right, yes.
So they work well in the sort of the male range, so maybe 200 or 300 up to 800 or 1,000, and there's sort of a linear relationship between the real and the measured value. Down here, where women live, even women with hyperandrogenemia, you know, there's not a good correlation between the actual testosterone and the measured testosterone. The assay is terrible. And so, you know, there's a movement of kind of afoot to standardize and upgrade the testosterone test.
Right.
So just keep that in mind that it's not a great test. Now, on the other hand, if you find that it's very high, like over 200, then you're out of PCO range. You're into, we need to think about tumors. But if it's in the PCO range, I would say it would be typically high normal to just a little above normal.
So your point is to me a very important pearl for our listeners. I think a lot of us will perhaps not act on some of the therapeutic ideas you're going to offer us about lifestyle modification if we see a normal testosterone in a woman who's hirsute. And so I think this is a really important really important point.
Oh, no, I think that testosterone is not something you should hang a big diagnosis on. So that's a really important point. So sometimes, though, somebody will come in, they'll have irregular periods, but they won't have any hair growth, and they'll say, do I have polycystic ovary syndrome? And so you can measure testosterone, and if it happens to be high, that's useful. And this is interesting. I've seen some Asian women who have very little hair growth, but they come in with irregular cycles, no body hair growth to speak of, and so I'll measure testosterone on them to see whether they might fit the criteria. Another thing that you can do is to actually do an ultrasound of the ovaries and see whether they meet the criteria for PCO. And it's a very specific criteria, so it's not just in the office, I see a couple cysts, it looks kind of like PCO. You have to meet specific criteria, the presence of 12 or more follicles in each ovary, measuring 2 to 9 millimeter in diameter, or an increased ovarian volume of greater than 10 cc's. So here we have to order pelvic ultrasound or transvaginal ultrasound and specifically ask them to do the PCO measurements. Otherwise, they won't do them.
So one ovarian cyst does not equal polycystic ovarian?
No, one ovarian cyst has nothing to do with PCO. And PCO does not cause pain. So people are real confused about, I've got cysts, I've got a lot of pain, I was in the hospital. And that is, you know, everybody can get those kind of cysts. But the PCO cysts are teeny, and they don't cause pain.
And they're multiple.
And they're multiple.
So,
so what do you do to rule out other causes? Well, these are the things to think about. Late onset congenital adrenal hyperplasia, I won't talk too much about that. Cushing syndrome, you want to think about that, especially in someone with high blood pressure or striae, or facial plethora. You want to think about an androgen-secreting tumor, and that would be a rapid change. You typically see a rapid change in hyperandrogenism.
And they viralize.
And they viralize. More commonly, you want to rule out hypothyroidism and hyperprolactinemia. So I always make sure there's a TSH and a prolactin on the chart somewhere, and then drug-related, like we said.
So if our listeners were looking at this list, they would say, what this woman needs is an endocrinologist.
Yeah.
So my query to you is, do all these patients with PCOS need to see you or see an endocrinologist, or can this be managed by primary care health providers?
I think it can be managed by a primary care provider who's willing to engage in a broad array of issues that are both metabolic and reproductive in nature. And what I think is best of all is if you're confused or not sure, send them for an evaluation, and then the PCP can certainly do follow-up.
Okay. All right.
We don't require LH and FSH anymore.
I missed this question on the boards years ago because they used to tell us to do this.
Well, it was for years the thing to do, and you do, it's true, have a high LH pulse frequency and amplitude, and you have a lowish FSH, but because, remember your medical school, the gonadotropins are not that many, are secreted in a pulsatile manner. If you just check at one time, you may miss a peak and not get the appropriate high LH to low FSH. And obesity is not necessary for the diagnosis. You can, many women, depending on what country you're looking at, are thin PCO women.
And that'll be, I'm not keeping a list of all the pearls you're presenting, but that actually is an important pearl.
It is.
Because I think a lot of patients will say, I don't think I have PCOS because I'm not overweight. And you have taught a lot of us that, the way you look isn't actually the initial diagnostic criteria sometimes. So.
Now, I think that the overweight women tend to be the ones who have more metabolic issues to deal with than the thinner women. Right. This is sort of a cartoon of the Fairman-Gallwey scoring system to give you an idea, and you can kind of see that, let's say, if you let's take the mustache area here. So a little bit of hair growth. This is supposed to be at the edges. This is then as it grows further in and gets denser, the score goes higher. And there are a bunch of different body parts that you look at to score. And so that's available if people want to use it and if they wonder what the Fairman-Gallwey score means when they're reading papers.
Okay. The numbers across the top end were 1, 2, 3, 4. And so what you do is if you've got a little bit on the mustache and it's 1, and then you go down to the genital area and that's 4, you keep adding them up.
Area a score.
Okay. I've always been taught that the back is actually particularly worrisome in females if you have a lot of hair growth on the back.
And this scoring system, you look at the upper back, and what's not shown on here is you look at the lower back as well.
Okay.
So this is an incomplete Fairman-Gallwey score. It's just meant to give an idea of how it looks. So the thing that surprises people is how common polycystic ovary syndrome is. Depending on how you define it, it may affect between 4 and 12%. It certainly is the most common endocrinopathy in reproductive aged women, and so it's out there. You've seen it.
Yeah, I have.
We've all seen it in primary care. You've seen it, and if you start asking about it, you'll be surprised at how many of your patients have it if you haven't been in the habit. And it's a heterogeneous syndrome. People don't all look the same.
I think you have to think about it, though, to ask the right questions. I think a lot of times people come in and they are immediately addressing the lifestyle modifications without absolutely thinking about why someone needs some of the lifestyle modifications. So this will be helpful in expanding our questions.
That's why the testing, I think, is useful, because it gives the patients a sense of what their situation is and why they should. Maybe it gives them a little more data to make their decisions about their lifestyle. So the thing that Andrea Duneif discovered and has been really held up over the years is that women with PCO have insulin resistance and type 2 diabetes. And so the numbers are between 50% and 80% of women with PCO have insulin resistance. About 50% have metabolic syndrome versus 12% in an NHANES study.
In that age group.
Because
yesterday I was reading something that said almost 1 out of 3 Americans right now have metabolic syndrome, which means in English you look to the right, you look to the left. One of those 2 people have metabolic syndrome.
Right.
So it's really going up.
And that a full whopping 40% have impaired glucose tolerance or type 2 by the age of 40. And impaired glucose tolerance is also called prediabetes.
Okay.
But lest you think that that's not a bad thing, You know, prediabetes means the horse is out of the barn.
That's right.
You know, you're already on the road to develop diabetes if you've already crossed over to impaired glucose tolerance. And so that's a lot of a young population with this.
So something I haven't heard you mention while we've been talking about how to diagnose PCOS is the hemoglobin A1C.
Yeah.
You know that the American Diabetes Association and other groups have allowed us now to make the diagnosis of diabetes with a hemoglobin A1C of 6.5 or greater. Can we use that in this situation, or is it not such a great test?
Well, you had, and you reminded me, you asked about the glucose tolerance test before, which is a 75-gram oral glucose tolerance test with testing at time 0 and 2 hours. That's all you have to do. So you don't have to do the 3 or 5 hour test.
Okay.
So it's a little simpler. The A1C is really, I think that we can use it if it's over 6.2 or 6.5, depending on who you read. You can say that person is at very high risk for diabetes and may in fact have diabetes.
Okay.
The thing that you can't use the A1C for is diagnosing impaired glucose tolerance. Right. It's not very useful in diagnosing impaired fasting glucose or impaired glucose tolerance. And so most of these patients are in that pre-diabetic category.
They're very early.
They're
early, so we won't necessarily catch it. Now, practically, though, do you order a hemoglobin A1C on your patients?
I am struggling with that.
Okay. And, me too. I was thinking I was the only one.
But I've been doing it, and the way I use it is that, you know, what we know is that the higher your A1C, between 5 and 6%, it's sort of a continuous increase in risk for diabetes and for for abnormal glucose.
Okay.
If the gold standard is the glucose tolerance test, and so one way you can use it is to follow a person over time and see their hemoglobin A1C rise in the normal range.
Okay.
And that can be because it doesn't have to be fasting, it can be a tool to give some feedback to the person of their trajectory over time.
Okay. Good.
But it's a
very helpful
question. I wish it was easier.
That's right.
So we're still on metabolic, M, my PCOS, M for metabolic. Okay. So Tracy Secchi and I'm so proud of her, my fellow. Yeah, we realized we were seeing a lot of patients with elevated AST and ALT and didn't understand why. This is years ago. And so we wrote the first description of fatty liver and polycystic ovary syndrome. My colleagues did not believe me when I told them that I thought that there was something going on. And then we did a chart review and found that quite a few young women have elevated ALT and AST, and our cutoff was over 60. And of course, with fatty liver, you know, it could be lower than that.
So our listeners are probably imaging right now a liver that is completely covered with yellow fat. Why do they need to worry about fatty liver? I mean, you know, this is a relatively new concept in type 2 diabetes. We've got an epidemic of the disease. Why do we need to worry about it, Anne? I'm not sure.
Well, because it is the most common cause of cryptogenic cirrhosis.
Okay.
And cryptogenic just means we don't know.
We don't know.
But it's a cause of cirrhosis.
Okay.
And so I have a patient right now whose mother died of cryptogenic cirrhosis, and she has fatty liver too. And so we're all over her, sending her to our fatty liver specialist, Dr. Anna Mae Deal. And I'll show you some pictures. This is Dr. Cap Haney showed. I was talking to him about this, trying to convince him that I was seeing fatty liver in patients, and he said, "Oh my gosh!" And he ran to his cabinet and pulled out these two pictures, and he says, "I took a picture when I was doing this operation, and I saw this bright yellow liver, and I didn't know what it was." And I said, "I bet that's fatty liver."
So my description was not so far off.
That looks like it. That is sort of all yellow fatty lipid deposit in that liver compared to what is probably a normal liver.
Now, Dr. Haney, just so we can all be clear, was a reproductive gynecologist.
Right.
So
we don't do
surgery. Yes.
We got no knives.
No knives.
So yeah, he was a reproductive endocrinologist here at Duke. And so this is another patient of ours that I had the elevated liver tests, and you can see fatty infiltrations, and then she did some exercise and weight loss on the order of 5 to 10% of her body weight, and walking 150 minutes a day, and she looked a lot better. And what you can't see here is that she had fibrosis already, which is the beginning of cryptogenic, which is the beginning of cirrhosis. And then here, some of that had gotten better, which is kind of a mystery. But the important thing is that lifestyle has a huge impact on these metabolic diseases.
So one of the things I think some of us struggle with when we're doing routine laboratory on patients with metabolic syndrome, the transaminases that you mentioned earlier can be just slightly elevated.
Yeah, that's bad.
It's bad. Now, do you send them right for liver biopsy, or do you do an intervention that you're going to describe here, I think, in the near future about lifestyle modification, and then just follow them? When do you have a feeling for sending them? Or do you...
Well, slightly elevated is bad, for one thing, so you want to make sure they don't have a chronic hepatitis. So I think anybody with elevated LFTs, you probably confirm it.
Right.
Kind of ask them about Tylenol and alcohol and things like that.
Right.
Drugs. And if it's persistently elevated, you need to work them up. And Dr. Deal doesn't always do a biopsy.
Right.
You know, I think it is just in certain cases.
Okay.
So I don't think you have to send everybody right away. But I think a reasonable thing to do would be to say this could work it up to make sure there's no hepatitis.
Okay.
Try some lifestyle modification to see if it comes down. If it does, that's great.
Okay.
She might disagree with me, but I think that that's a pretty.
But adding to the string of pearls here is don't ignore the abnormal transaminases in a patient that you're worried about having metabolic syndrome, whether it's PCOS or otherwise.
Right. It'll be a little blip that you don't really notice that much, but it's very important.
Okay.
So, those are sort of the metabolic things to think about under metabolic. Okay. The diabetes, the blood pressure, the fatty liver, the lipids.
Okay.
And this slide is meant to talk about what is the connection between insulin resistance and hyperandrogenism. I mean, why is it that women who have polycystic ovaries also have a beard?
Okay.
And so what we know is that there's probably an increase in GnRH pulse frequency right in the hypothalamus. That leads to that relative suppression of FSH, and you have a higher LH pulse amplitude and frequency. And so that, in combination with elevated insulin, so the high LH synergizes with the high insulin levels, goes to the ovary, the theca cells in the ovary, and stimulates testosterone production.
So the testosterone's coming from the ovaries.
Testosterone comes from the ovaries, and it's the insulin is helping to drive ovarian testosterone synthesis.
Okay.
Which means that if you can lower the insulin level through diet and exercise, you might be able to lower the testosterone a little bit as well.
Okay.
So the key thing is that hyperinsulinemia, which is this metabolic part of PCO, drives another part of PCO, which is the testosterone.
So this is going to lead us to therapy eventually. So anything we can do to drive the insulin level down will actually fix the testosterone. So we don't need to be trying to give medications to decrease testosterone.
Well, it is. I would say that is in theory true. In practice, it probably is hard to lower the insulin levels enough to really lower testosterone. Okay. And I'm not sure this is the only reason that testosterone is elevated.
Okay.
You know?
All right.
So, all right, so here we are back at the therapeutic issues, my PCOS, and we've spent a lot of time on metabolic because we're endocrinologists, right? It's the most important thing.
Right.
But I think it's also important that you think that we as physicians, no matter what our field, think about some of the other things too, like the next two are going to be reproductive and psychosocial. So, So this may be a little bit out of order, but the metabolic workup suggestion is the 75-gram oral glucose tolerance test, which we talked about, a lipid profile, and liver function studies. I particularly recommend that for women with PCO who are obese and or those who have a family history of type 2 diabetes, if you're wondering whether to do it on everybody. I don't always do it on thin women.
Okay.
So these are the metabolic targets we've talked about. And my first strategy is always lifestyle management, the TLC, therapeutic lifestyle changes, nutrition, activity, and stress management. It is not going right to insulin sensitizing drugs.
I was on TLC as tender loving care, which I thought actually also applies.
It's very appropriate.
Absolutely.
It's very appropriate. That's where the stress management comes in.
That's right.
And that's a mystery to a lot of women I see.
Yeah, that's right.
And the reason I put this slide in is to show that lifestyle therapy is extremely important, and it is a first-line therapy. And one of the reasons that we like it so much, we're borrowing from a trial called the Diabetes Prevention Trial, which was done not in women with PCO, but it was done in people with pre-diabetes, that impaired glucose tolerance, which a lot of women with PCO do have.
All right.
And lifestyle therapy was compared to metformin therapy, and what the outcome was diabetes development. Lifestyle therapy beat metformin therapy.
And I try to convince patients about that all the time. You know, did they do a subset analysis of PCOS women in this study?
I don't think they asked about it. These were all older patients anyway.
Okay.
So they didn't ask about.
But I think it's. I mean, since metabolic syndrome is metabolic syndrome, if you've got evidence that lifestyle modification can affect it, then we should apply it in PCOS. I think. You know?
And similarly, I think that I want to emphasize that the metformin was used in patients who had impaired glucose tolerance. Remember I told you that the horse is out of the barn once you have impaired glucose tolerance. Your pancreas is already pooping out, and you're going to get diabetes if you do nothing.
Okay.
So the vast majority of patients that we're going to see who are young women with PCO do not have impaired, some of them will have impaired glucose tolerance. A lot of them are being put on metformin even if they don't have that prediabetes, if they're sort of pre-diabetes. And that's something that I think we need to be careful about. And there's different styles. Some people use it and some people don't. But I think that, you know, my strong, you know, preference is to work really hard on lifestyle therapy.
But, you know, a lot of physicians and healthcare providers and even patients feel like if you can cure it with a drug, then we use the drug. So I'm hearing from you that metformin doesn't cure it.
No, it doesn't cure it.
Okay.
And it's not as powerful as lifestyle anyway if we use these data as any indication.
All right.
So TLC, therapeutic lifestyle change, is the first-line therapy. And one thing that a recent study that was published actually was very hopeful, looking at exercise. And it showed what has been shown in other studies, too, in non-PCO patients that exercise. Even if you don't lose any weight, if you just exercise, it improves insulin sensitivity and triglycerides in this study. And so,
now, was there an amount of exercise, Ann? I always tell patients the 10,000 step rule, but I'm sure that, you know, 3 times a week, 45 minutes? Or?
I think, you know, the 150 minutes of activity per week, which is 30 minutes 5 times a week. So brisk walking, at least, you know, 30 minutes 5 times a week. More than that and more intensity is going to be necessary for weight loss.
Okay.
I think insulin sensitizers are very optional. These are young women. You're committing them to long-term therapy. I think you want to do it cautiously.
Okay.
I use metformin mostly. I would say I never use the thiazolidinediones in this population because I think that the potential risk of edema and weight gain are maybe more than asymptomatic patients would want to
that's fair.
To endure.
Okay.
Okay, now we're at cycle control, and we could get into a lot of detail here, but I think that it is important to pay attention to. And what you want to do, just think about PCOS as essentially being unopposed estrogen exposure to the endometrium, because if you don't ovulate, you don't make progesterone and cause that endometrial shedding. So it's like taking unopposed estrogen, and you are more risk for developing endometrial hyperplasia or cancer.
Okay.
So you need to pay attention to that. It can also cause, you know, one of the symptoms can be heavy anovulatory bleeding, and you want to manage that, and you also want to manage contraception in young women, particularly if they have diabetes. Right?
Define manage contraception.
Yeah, okay. Well, you want
that's a problem
to talk about contraception because unplanned pregnancies in somebody with hypertension or early diabetes could be a problem.
And what we often see is, since these periods, as you said at the very beginning, are very irregular, a lot of women will assume that they're not ovulating.
Yeah, and they're not fertile.
And they're not fertile, and then they'll not use contraception.
Surprised.
And they will be
surprised.
They will be surprised.
So I think that the key points I want to make here are that any birth control pill pretty much is fine. There are some that are marketed as being more anti-androgenic than others, and those are fine. But really, any pill, the lower the dose, the better. And seasonal cycling is becoming more popular, where people take, instead of taking a pill pack for a month and then having a period, pill pack for a month, have a period where you take 4 packs of active pills,
okay.
which is 12 weeks.
Okay.
And then have a period 3 times a year.
So you actually encourage people to have endometrial sloughing?
Yeah.
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 Okay.
And they don't have to do it more than 4 times a year.
I wonder if they wanted to use this for contraception. Will that work?
Yep, that'll work just fine.
Okay, because you're not ever ovulating.
You're not ever ovulating as long as you're on those pills.
Okay. All right.
If somebody already has hypertension, then they should not use an estrogen-containing pill, and so don't forget about the progestin-only pill if you have a hypertensive or a smoker.
Okay.
If you don't want to use oral contraceptives or the patch or the ring, contraception isn't an issue. You can use cyclic Provera or any other progesterone.
All right.
And so think about cycles. I think psychosocial, I think patients really appreciate it if you can ask them about what this means to them. They've often had prior bad experiences with providers who minimized their symptoms or told them that everybody has a little hair or you just need to lose some weight or don't come back unless you want to get pregnant. They felt dismissed. So I think listening is important. And I screen all patients, just a reminder, for trauma history.
Okay.
And I think just non-judgmental listening and acceptance goes a long way. And reinforcement that PCO is an important medical problem, and you appreciate them bringing it up. Now, the other big issue
this is the big one
that comes up is, what do I do about the hair growth or the acne? And the estrogen in the birth control pills does double duty here.
Okay.
And it can lower the testosterone and raise sex hormone binding globulin, which is helpful for hirsutism. And like I said, most current oral contraceptives have equivalent effects on androgen suppression.
So you're repeating that you don't really care which brand people use the lowest dose.
I like to use the 20 microgram pills if at all possible, and those are the lowest dose available now that I'm aware of. And I think that I like to use generics when I can. And so you can also add spironolactone, 100 to 200 milligrams a day if birth control pills aren't enough. But it is that's an androgen blocker.
Right.
But
looks at the hair follicle.
Right. Right. So it's a teratogen though, so it can make a male fetus look more like a female fetus, so not so good there. So it always must be used with adequate contraception. And then for the androgenic alopecia, the loss of hair, I tell them to get Rogaine, and Rogaine for men is fine. They do need contraception when they're using it, but Rogaine foam, Rogaine in whatever form. Vanica is another cream that can slow hair growth.
Right.
And
I've had some patients use that on there.
Yeah. I don't think insurance covers it in most cases, and so it is expensive. Right. I think laser hair removal is remarkably effective, and it's important to know that it relies on the difference between light skin and dark hair, so it won't get blonde hairs. African American and darker skinned women need to use a particular laser. And insulin sensitizers, I mentioned they could decrease insulin, and so there's been some studies that tried to show a reduction in hirsutism. But
so, Anne, here's a question my middle-lifed patients will ask. Will I have to do this forever, or does it slow down as you get closer to menopause?
At menopause, estrogen fizzles away as the ovaries retire. And so the balance
I like the way you put that.
So the balance becomes actually more toward testosterone.
Oh, that's right.
So I think people just stop caring at that
there you
point.
go.
I think
that's probably
my
right.
patients, they don't like it, but they're not so worked up about it. So I don't think it gets better. That's why I just go ahead and get the laser.
Right.
All right, so I know we're kind of pushing the time. One thing I want to say about ovulation and fertility, which is the O in my PCOS, is you need to think about fertility and let people know that the earlier they can get pregnant, the better it is biologically. Metformin, weight loss can help with pregnancy, with ovulation. Metformin can as well. And we used to use it for ovulation induction for people who wanted to get pregnant. But a randomized controlled trial done in part here at the DCRI showed that Clomid actually was better when you measure live births. So they both help with ovulation, which is a problem in PCO, but if you look at the take-home baby rate.
Sustaining the pregnancy. Is that, so just to rephrase what you said, would there be less chance of miscarriage if you had a pregnancy induced with Clomid than if metformin, or is that not really the right
that
result?
wasn't the result.
Okay.
It wasn't worded in that way.
Okay.
It's just
healthy baby at the end.
Healthy baby at the end.
Okay.
So I don't know at what point.
So we get asked a lot as endocrinologists whether a woman with diagnosed PCOS should be put on metformin prophylactically as they try to get pregnant.
No.
And the answer is now no.
It's
and that is a
no.
new bit of information over the last couple of years.
There have been a lot of studies looking at whether there's less diabetes, less preeclampsia, less miscarriage, and there's no good data that metformin helps.
All right. Okay.
So the other thing is that metformin can increase ovulation, so it could increase fertility. And so if you have a patient who is young and premenopausal and you put them on metformin because they have diabetes or impaired glucose tolerance, remember that they could get pregnant. This was brought home to me when we rounded on the diabetes management service on a 40-year-old woman with an unplanned pregnancy who was delivering because she'd got put on metformin. So
metformin baby, we call that.
She's a metformin baby.
That's right.
The most recent thing that I think can be really helpful in taking care of patients is the realization that sleep apnea is more common in women with PCO. And I don't think there are really good numbers out there, but in one study it was 17% versus 2% PCO versus general population. And then if you look at people matched for BMI, PCO versus non-PCO, it's 56% versus 19% in that study.
Now, and practically, when you are evaluating a patient for possible sleep study, do you assess that based on their girth, or the slender patient gets a potential sleep study, or you do it by history? How do you decide?
I ask them things like, interrupted breathing during sleep, habitual snoring, excessive daytime sleepiness, GERD symptoms, and morning headaches. And it's more insulin resistance was more strongly predictive of obstructive sleep apnea than BMI or testosterone.
Okay.
All right. CPAP, very awkward, but it does help, and it improves insulin sensitivity.
I know. I tell patients they're going to feel better when they use it. Then they say, but have you ever used it? And it's sometimes tricky. So I always tell patients, if you're having trouble using CPAP, go back and get the mask refitted, or there's some other option sometimes.
And even if you can just do it for 4 hours a night, that's better than nothing. All right, so now comes the time to summarize therapy. So metabolic, think about nutrition, activity, stress management, weight loss, insulin sensitizers, which are optional. Cycle control with oral contraceptives, progestins, weight loss. Psychosocial, support. Cosmetic, estrogen-containing oral contraceptives, maybe spironolactone if that's not enough, and you can consider some of these other medications, but the big one is the oral contraceptives with estrogen. And then for fertility, activity, weight loss, and then possibly metformin, though I should take that off because that really is
not used too much.
Right, it's not a first-line therapy.
Okay. And you left off S, which is sleep apnea.
Which is sleep apnea. You are right about that. I need to update these slides.
That's right.
So patients often complain of fatigue, and this is a good place to go with them to sort out whether they have PCO.
So what happened to our patient?
Well, it progresses with time. So her oral glucose tolerance test 2 years later showed a glucose over the 140 cutoff. So she has impaired glucose tolerance. Her blood pressure's up there.
So did you repeat the glucose tolerance test every couple of years?
Yeah, I had been doing that for a while, and I tend to do that if I do long-term follow-up.
Okay.
And though, the A1C might be, hemoglobin A1C might be a better way to do that, more convenient. So she's on oral contraceptives with 20 micrograms of ethinylestradiol, and so that blood pressure is a little concerning. And you can either stop it or add a blood pressure medicine at this point. Right. So we talked about, because she has impaired glucose tolerance, we talked about more about lifestyle options and metformin, and then options for blood pressure management. And 4 years later, she did stay on the oral contraceptives, and she came in feeling lethargic. And now her fasting glucose is 171, and random glucoses are over 200, and her blood pressure is up even higher. Okay. And so now she has diabetes, elevated blood pressure, and we are using metformin, and we're going to discontinue the estrogen-containing oral contraceptives, and we switched to a progestin only because she's still premenopausal, and started blood pressure medicine.
So your decision to start metformin was based on the eventual development of type 2 diabetes.
Yep, you can argue that we should have started it sooner, but it's a partnership with the patient about what they want to do and how much they want to try lifestyle therapy. The real nice advantage of diagnosing this early, talking to a woman with PCO early on in the preclinical kind of the earliest stages, is that she can kind of begin to make lifestyle changes, learn to understand what works for her, and then by the time diabetes develops, if it does, we're sort of prepared. This was not necessarily a great success, we didn't prevent diabetes from developing, but she wasn't surprised when it happened.
And thank you for such an excellent discussion of an increasingly more recognizable disease among women. Thank you.
My pleasure to be here.
Our guest faculty today has been Ann Brown, one of my colleagues here at Duke. Ann, thanks again for joining us for such a great discussion. Until next time then, from all of us here at Duke, this is Diana McNeill saying thanks for joining us and take care.